I'm going to talk about surgical management, which has had an interesting history in that before botulinum toxin, this was the only treatment from a potential cure point of view that we spoke about earlier. So what's the background? So before toxin, there were limited options to treat this condition. And so some of the current surgical techniques are shaped by what techniques were out there pre-toxin. And in oculoplastics, which is our field, our subspecialty, often nothing is new. Most techniques have been tried many, many years ago, often over 100 years ago. So often there are differences on the theme that have already been developed. And most of the techniques have centered around the orbicularis muscle, unsurprisingly. So what of the orbicularis muscle? It is extremely strong. If you have a squeezing patient, you're trying to examine them, you know how strong it is. And of course, as sufferers of Blepharospasm, you all know how strong this muscle is. So what are we trying to achieve by operating on this muscle? And we know also from previous slides, there are different parts of the muscle. There's the muscle in front of the lower part of the eyelid. There's the muscle in front of the upper part of the eyelid, above those areas, and also the lateral raphe. This is really very, very important on the lateral side, and there was talk about techniques to press on the lateral side of the orbit or the eye socket. And really there's a very, very strong condensation of the orbicularis muscle at this point. And often that injection is really important if you're trying to treat blepharospasm. It's also one of the more painful ones, as I'm sure a lot of you know. Some people call it a tendon. It's not really a tendon, it's more of a condensation of the muscle. What I'd like to do is to try and look at different aspects of this, what looks like a run-of-the-mill photograph of an eye. But have you got the pointer still? Sorry. So when someone gets referred with, let's say, a droopy eyelid, we really need to look very carefully at what that referral is. A lot of GPs send in a droopy eyelid referral. Is it the eyelid? Is it the eyebrow? It's surprisingly common to have a droopy eyebrow. And is it just the upper lid, or is the lower lid moving in this direction as well, which would alert you to something like a blepharospasm? It's really important to think about these things, especially when you're thinking about surgical approaches. So what are the options? A lot of focus is on a myectomy, which is essentially removal of muscle. And of course, we're talking about orbicularis muscle in the main. But people have removed a lot more than that. So things like the procerus muscle, the sort of frowning muscles in between the eyebrows there. So you can have a total myectomy where you try and remove every single shred of orbicularis muscle you can find. That's interesting. Even if you try and do that, you still have quite a strong function of eyelid closure, despite trying to chase every muscle fiber. You can do a partial myectomy, remove a bit. You can remove muscle from the upper eyelid and then the lower eyelid at a later stage. You can lift the brow. So often it is not just the eyelids that are involved. It could be the eyebrow that's involved. And if the eyebrow is contributing in a significant way to the problem, you could lift the eyebrow. And you can also lift the eyelid. And often with blepharospasm, you might think of lifting the eyelid by connecting it to the muscle of the forehead, the frontalis. So what we call a brow suspension procedure. And interestingly, there's some other curious techniques like a myo-osseous fixation where people have used screws to try and fixate the orbicularis muscle to the eye socket rim or the orbital rim. And obviously a combination of the above, potentially. So what are the indications for surgery? A so-called failure of botulinum toxin, we'll come to that later. Apraxia, so once a spasm has subsided, an inability to open the eyes. A lot of people are frustrated by this because it's not understood. People are focusing on the spasm, but some people take ages to open their eyes again. And that's something that has a specific surgical indication. So what do we mean by failure of botulinum toxin? I think we're very quick to jump to this conclusion. I think it's very, very important that after you've tried botulinum toxin, to check the function of the orbicularis. you know, well, you should have tested the function of the bacillarius before you've injected the botulinum toxin and documented that. If you've given toxin and brought the patient back and they feel that it hasn't worked at all, I would then check the orbicularis function. Because if you find that it's weakened, then you know the toxin has an effect on the muscle. It may not have had the outcome that you want, the complete outcome for the patient, but you've achieved something in the paradigm that you're trying to go down. So if the orbicularis is weakened after toxin, there may be other factors involved, and then you might be looking at the brow and so on, and the eyelid for things like ptosis and brow ptosis. And if you have a droop, is it the brow or is it the eyelid? Or is it both? And so back to this again, focus. Is it that? Is it that? Is it both? Is it just the blepharospasm or is it another factor or a combination of factors? So careful assessment of all the possible factors will allow a potentially more systematic approach to the problem. And so what do I think? Well, a trial of toxin, of course. This is the mainstay of treatment. A failure of toxin, are you having some effect on the muscle or not? If you are having some effect, I would then use the toxin, but use something else in combination. If you have absolutely no effect, then you might want to look at other options. So in severe cases, you may want to try and chase all the muscle fibers. In apraxia cases, where you can't open the eyes, you may want to consider a brow suspension procedure. You might want to consider both, and you might want to stage the surgery. If you try and do too much surgery at once, it can have a lot of side effects and may not be beneficial. And you might want to combine this with botulinum toxin. So are we moving towards more combined treatment? A note of caution, though, before I finish, surgery involves side effects, full stop. There is a romantic notion of surgery, going under the knife to solve your problem. But we know as surgeons that there's always a consequence to surgery, and that can be a negative consequence. So what is the evidence to support surgical treatments? Extremely weak. Case series, essentially reading a proponent of a technique and their series. So all sorts of problems with selection bias, no control group, and I don't need to go on. And that's why we're having days like this, really, to try and improve the evidence base. Thank you very much.